So for those who don't know me, I'm Dr. Noah Berland. Recently finished my medical toxicology fellowship at Rutgers and JMS and went here for residency and now back. If you don't know the original Willow, I think there's now like a really terrible one on Disney that reenacts it, but it's not the original Val Kilmer movie. So we're going to talk about aspirin. I'll still hold this though. So objectives today, how to describe the basic, most important mechanism of toxicity, identify toxicity, and then explain therapy. So we'll start with a little bit of a case. So we have a 4-year-old boy who's brought in by their mom for nausea, vomiting, and just not looking right for about an hour after eating something in the bathroom he thought was candy. Kind of know where we're going. So here are the vital signs. 4-year-old, are these normal, abnormal? What's abnormal? Let's work. Yeah. So tachycardic, very tachypnic, and how are they measuring the temp? So maybe actually febrile. All right. So here's the exam. So tinnitus from aspirin is more of like a whooshing. It's not that ringing sound that we think of tinnitus usually. They're very dry. They're covered in vomit. Their lungs are clear, but they're very tachypnic, tachycardic, and they have some epigastric tenderness. So just to why I even mentioned Willow, it's one of the sources originally of aspirin that was discovered, as is meadowsweet. It was described by Hippocrates as a treatment for like all your ailments, and then kind of slowly over time, pharmacists and all throughout Europe started to isolate salicylic acid, not acetyl salicylic acid, and use it for ailments, fever, rheumatism, all of those things that were affecting, sure, syphilis, just the cure-all. But it was very difficult for people to tolerate. It had a lot of GI distress, and so this gentleman here is Felix Hoffman. And so he's famous for kind of two main things working with Bayer, aspirin and heroin. So aspirin is kind of alluded to this as acetyl salicylic acid. So salicylic acid with an acetyl group. Do you guys anybody know what heroin is? But what's its like chemical name? What's its fuller name? Anybody? Nobody? So it's diacetylmorphine. So he essentially, for both of them, did the same thing to make them more, whether in the case of aspirin, more tolerable so that you're not vomiting up like crazy and getting gastritis, by using essentially acetic acid vinegar to take salicylic acid and make it into acetyl salicylic acid. Or in the case of heroin, adding, again, essentially vinegar, acetic acid, and replacing two hydroxyl groups with acetyl groups to make it more euphoric and enter the CNS more quickly. So that's what Felix Hoffman kind of did with Bayer and made lots and lots of money for them. And, heroin's great for coughs. If you take too much, you'll also probably get an aspiration pneumonia eventually. Cough. Partly why you get the aspiration pneumonia. All right. So as I said, this is salicylic acid, and you can see, here's our same carboxylic acid, and then here is that, this thing is weird. Here's that hydroxyl group I mentioned, replaced with an acetyl group. And then this is oil of wintergreen, and the pointer, which is replacing essentially that hydroxyl group on the carboxylic acid with a methyl group, and that's oil of wintergreen. There have been cases where people purchase this 100% pure wintergreen, which 1 teaspoon is essentially like the equivalent of a single pill killer for children, so 5 mLs. But people will buy this thinking, oh, I'm going to make Christmas cookies for the whole office. I'm going to make them mint. I'm going to flavor them. I'm going to make, peppermint bark. But they got oil of wintergreen, and then they end up poisoning their entire office or school. And this is probably, you know, per gram more toxic than salicylic acid. So you have to be really careful. Some cleaning supplies have it, but they usually have other things in it that make you vomit up, and you're never going to get enough. But every now and then, somebody has a pure extract lying around and can get quite sick, especially children.
The worst ones I've ever seen of what have been boiling.
Really?
Oh yeah,
because it doesn't take that much. They're usually extreme. That one was, 100% pure wintergreen. It's very concentrated. So realizing on this screen how is aspirin toxic, mitochondria is not showing up probably very well. This is the most important thing to know about the toxicity of aspirin. It also interferes with fatty acid metabolism and works centrally on respiratory drive. And as we said, it's a really terrible GI toxin. But this is the main thing. So it's a uncoupler of oxidative phosphorylation. And this is essentially how it ends up working. It ends up literally going through the lipid bilayer and allowing hydrogen ions to cross the mitochondria inner membrane, which then ends up getting rid of the gradient. And so then ATP synthase is no longer working. And so that's why you end up generating heat. People get febrile, they get lactic acidosis or lactate associated with an acidosis because they're not able to actually jump those final electrons on or even generate any energy. And so they move into anaerobic respiration. And so this is partly why people get so sick. And this is different than cyanide that doesn't actually uncouple. It just interferes with, I think, complex 4 and prevents the electrons from going on. So in some ways, this is like a little worse and scarier. So targets, and this is not complete, but these are the main ones we think about: kidneys, GI, CNS, and that's really where we want to keep it away from. And lungs, you can get really terrible pulmonary edema. But it really is toxic to all organs. And these are the sickest patients often in the hospital. So how do you identify it? Unlike the next lecture, where you kind of have no way of seeing it, especially early on, aspirin kind of has a very clear toxidrome to look out for. And some people would argue for aspirin, unlike, and this is really all talking about acute toxicity, you should be able to identify acute toxicity pretty easily. And sending screening labs, say for like psych or aspirin, is very unnecessary in all probability. So, you can get febrile, as we talked about, because you're uncoupling the electron transport chain. You get tachycardic, you get elevated lactate levels, you have a high anion gap metabolic acidosis. And even salicylates themselves are an anion that can elevate your anion gap, not just the lactate that's formed. You get this very kind of almost pathognomonic, like mixed respiratory alkalosis and metabolic acidosis, because it's a central driver of increasing your respiratory rate. And so early on, people aren't even acidotic. They're often just tachypnic, alkalotic. They're also vomiting a ton. And so they're also getting more alkalotic that way. So they even have a little bit of a mixed metabolic alkalosis. And then they develop this metabolic acidosis, which, when their pH starts to become more normal, that's when you get really scared about these patients. When they're tachypnic and they're able to maintain their drive, then you are a little less worried. It's earlier on. So tachypnea, and then you often get this like tinnitus, confusion, mental status changes. And they used to dose way back, maybe in Dr. G's day, to tinnitus. If you're getting an adequate dose of aspirin, it means you should develop tinnitus. If you don't have tinnitus, you need to get more. And that's kind of similar to colchicine, where if you're not having explosive diarrhea, you don't have enough colchicine. But some people get toxic before they actually get the explosive diarrhea or the tinnitus. So poor markers of therapeutic levels, which is why we don't do that anymore. So the mainstays of treatment are, first kind of with everything obviously A, B, C, D, E. So resuscitation, these things are kind of in parallel, but you always want to decontaminate somebody. This is generally not external decontamination, internal decontamination, resuscitation, shifting and excretion, so removal from the body and preventing it from going into the compartments that we don't want it to go into. And then, just removal via extracorporeal removal, hemodialysis. So this is activated charcoal. It's actually, the first dose is not so bad, on like the left and the middle. It's generally with sucrose. It does absorb salicylate pretty well. And so it's something that we really use to reduce their levels and reduce the probability of toxicity. When to give it is a little bit more complicated because these people are vomiting a lot. You often need to control their vomiting first. The longer out, which we'll talk about in a little bit, you get from giving activated charcoal, the less effective it might be. So most people, for like a single acute ingestion, around 2 hours, but everybody has a different story. And then you could always do gastric lavage, which is just difficult. And though historically people did it on awake, unintubated patients, you really very rarely do it on awake, unintubated patients. And these patients, as we'll mention, you really don't want to intubate them. So unless there's super sick, there's nothing else you can do, and you're taking their airway, would rarely, or it's just such a massive overdose, would rarely recommend gastric lavage for these patients. But it is something you might have to do, and I know of at least a few people who've had to do it because the patient's so sick, can't control the vomiting, and they just tube them. And then they generally don't even know what's going on before. All right. So the reason to maybe extend giving activated charcoal, especially for aspirin patients, is they can form concretions or bezoars of aspirin in their stomach. So especially our enteric coated aspirin, they'll all just kind of clump up together in these big gigantic concretions, and they can actually have prolonged absorption over days of aspirin. And so you can keep giving them activated charcoal essentially to kind of keep bathing that to prevent it from going into the bloodstream and going, just into the GI tract and eliminate it that way. So we will generally, until the numbers start to go down, keep recommending like Q4 activated charcoal multi-dose. The first one has the not super fit. No, it's a cathartic, but it's also like sweet. The first dose has that, and then the next ones you don't do it, but most places only have it with the cathartic. But so you just keep doing this until you at least get a level or falling off level from what was initially obtained. Resuscitation, these patients really, as described in this kid, they're vomiting, have massive GI losses. You generally don't know their pH or any acid-base status when they first show up your door. And so these are 2 large bore IVs, and giving them for a kid 30 cc's per kg right off the bat, if not, and then starting them on like 2 times maintenance right away because they're so sick and so dehydrated and look so terrible. And then as we start getting back everything else, the level, then we can talk about the next step, which is alkalinization. I don't know why this showed up, but essentially it's just a deprotonated carboxylic acid there. And this is kind of the mainstay of what we recommend as the therapy for treating aspirin toxicity, which is kind of switching it from an uncharged carboxylic acid, which is kind of a weak acid, so it stays in this protonated form for most of its time, and then we want to deprotonate it, make it into the base, and then shift it out. And so this is kind of the basic idea. At physiologic pH, you kind of have an equal shifting between blood, urine, and CNS, but we don't want it to go into the CNS. Only unprotonated, as I think we all know, molecules really cross the blood-brain barrier unless they have, some type of facilitated transport. So they're able to easily cross when they're unprotonated, and then they can get trapped in the CNS and cause all of the sequelae of toxicity that we're trying to avoid. And so we're aiming for a pH of 7.5, 7.55 to make it so that they're not crossing the CNS, go into the urine, and then get trapped in the urine and get eliminated. So what we do with that is sodium bicarbonate. Um, you know, depending on the text, they might say 2 to 3 amps, which is 100 to 150 milliequivalents of sodium bicarb D5W. I'm running this for adults at like essentially 2 times maintenance to get there. Adding 40 milliequivalents of KCl, which I'll mention in a little bit, is really important, and really closely watching that. For kids, it's somewhere between 3 to 4 cc's per kg an hour. And I've seen both kids and adults come in. You really need to give them a lot. And this is not like with TCAs where we're aiming for also having like a hyperosmolar hypernatremia. We're just trying to make the pH get changed. We're not trying to increase the sodium amount. So then there's extracorporeal removal, as we mentioned. For any time that you're thinking about doing hemodialysis for a toxic substance, always look at X-Trip. Have you guys heard of X-Trip? No. But this is the Extracorporeal Treatments and Poisoning Working Group. They essentially work with a group of toxicologists, nephrologists, critical care doctors, and come together and decide based on the evidence. It's not perfect because a lot of the evidence is often lacking of when to, pull the trigger on extracorporeal removal. And then they'll say what type of ECTR they're recommending, whether it's HD, CRT. And so the number that you should remember for the boards, I think, just remember the 100 milligrams per deciliter. It's also read by Europeans and other people with more reasonable SI units. So that's where the 7.2 millimoles a liter comes in. But 100 milligrams, that's definitely on your board exams on the in-service. So that one you should know. The 90 in impaired kidney function, I don't think they're going to test you on that, but know that if they have an AKI, again, it's toxic to the kidneys, you're more likely going to have to pull the trigger. Also, if they're not urinating, it makes sense. You're going to have to, remove it at a lower level. If they're altered, and this is because these patients get so sick, they tire out. And once you think it's already gone to the CNS, then you just have to remove it. And so that's why that's a 1D recommendation. If they're developing APE, again, we're fluid resuscitating these people, then we have to remove fluid from them. And so that's why that's one of the 1D recommendations. And then if they're just failing bicarb. Does that make sense, Dr. G? Correct. And I'll very briefly mention chronic because most of what we do is acute. Chronic is probably a little bit more straightforward in that if you find one, you'd probably just hemodialyze them. Yes, this is all just for acute. And then, do you guys intubate? If you have to, you have to, but you do everything you can to not intubate them. If you do intubate them, what have you guys read about? And I think these are things also on the board exams and probably shows up in Roche. So what do you do for their respiratory rate? So at the minimum, you want to try and match what they're doing. Now, if they're already acidotic, then you're not doing that, then you're going above. But your aim is, you never want to go, oh, I'm going to set them to a respiratory rate of 20. They were breathing at 30, and then you kill them. This is not the time for, the no offense to, first years or anything. This is the time for the senior or even the attending to do this to the person who is the most comfortable and the fastest. This is not the tube to play around with. You want to really optimize them as much as you can. Generally, it's give them, bolus of sodium bicarb right before doing it as well, because you do not want the moment their respiratory rate drops to then have to, immediately just bag them up and, miss that opportunity when now they shift into their CNS. So this is your literally fastest intubator who can do it as efficiently as possible, who you give the bicarb and you're, matching their respiratory rate. And sometimes they're not tachypnic, they're just hyperpnic. They're taking really giant breaths. And so you need to take that into account. Like, are they hyperpnic even if they're breathing at 20 and they're pulling massive tidal volumes? And then you need to give them really large tidal volumes, because at the end of the day, it's minute ventilation, not just respiratory rate. Having, I'm sure you guys have seen this. Patient gets intubated in CCT, not even aspirin. And, the person was hyperpnic and that's not taken into account. And now they're pulling really tiny, tidal volumes, and their minute ventilation has actually gone down substantially to what they were doing themselves. And now they're really acidotic, and that needs to be fixed. Yeah. And I think usually it's they weren't even thinking about how dangerous it is to intubate them when they do die in these cases. They're just, oh, you look sick, I'm going to tube you. But these are like the scariest patients to intubate. There's like probably no other, I guess if they were morbidly obese, they might be scarier. Yeah, all those things. But then maybe you're just doing a cripe. I just would give it right before I'm tubing them. Yeah, I mean, you're hopefully not tubing them, but you're doing this because you're like, they're failing. They're already like acidotic. They're, tiring out. But yeah, I would just give them 2 to 3 amps personally, and just hit them really hard. You're not gonna match them with the bag, and they're gonna have a lot of time when they're not being adequately ventilated. I think if you can delay, then you probably don't even need to tube them at that point. Oh yeah, I think whatever you can do to make it as smooth and quick as possible, whatever, the comfort of the intubator, whether I'm going to bag them up and, you know, very comfortably are going to try and hyperventilate them by bagging them while they're um, sedated and paralyzed. I think whatever makes it quicker, that's what matters. And then, don't let the respiratory therapist just do the default settings, because I think that's where we all fail often. The COPD or respiratory therapy just puts in the settings and walks away. And this is like really a discussion with RT and going through the settings even before you hook them up, like having it set to like what they're breathing, and making sure they have an adequate minute ventilation. But try not to intubate them. That's like the number one thing. So, there are some pitfalls to dealing with aspirin that you should just be aware of. So I mentioned this before, potassium is really important. You can't, our body through aldosterone will always kind of preferentially try and, pull back. If you're hypokalemic, we're always going to choose to resorb potassium distally and secrete those ions in the kidney. And so that's just something you can't fight against. As if you're hypokalemic or even like normal low potassium, you're not going to alkalize the urine. It's going to be normal pH or even acidotic, because you're dumping in, hydrogen ions to pull back in potassium ions. So these are patients that you want to make sure that they have high normals, potassiums. That said, if you do this, at the minimum, if you're alkalizing them, you're keeping it out of the CNS. You're not eliminating it as efficiently as you otherwise would, but they're at least not hopefully getting more toxic. But watching that potassium really closely. Some people look at the actual urine pH, although that just becomes a distractor. Like if I tell you to do 10 things at once, and I say also check their urine pH, it's a little bit too much to keep track of. But just making sure that you're following their potassium and that you're keeping them replete, and because otherwise you're just never eliminating it. So this is this neuroglycopenia. It's kind of more case report based, where there have been people who have been altered from aspirin toxicity. They get LP'd, somebody checks the CNS glucose, and they had already done like a finger stick, or they just done blood, and their glucose is totally normal on the blood, on the finger stick, but their glucose in the CSF is actually like hypoglycemic. And so we're not saying to LP these patients, like aspirin patient, definitely please don't LP the patient to test this out and to, see if this is true. Just give them dextrose. And that's like the real key is like altered patient who's otherwise like breathing well, try dextrose first. Obviously, we're concerned, they're altered. We're immediately getting, you know, renal involved, but we're hoping that if we give them an amp, well, really 2 amps of D50, like I would go for a full, 1 gram per kg of glucose. And remember, one 50 ml amp is only 25 grams of glucose. So for most adults, 2 amps is probably more appropriate than 1 amp of D50. And you always have to look for rebound hypoglycemia if you're using D50 instead of like D10. I like D10 for most things, but for this patient, probably D50 is the way to go. 2 amps of D50, so 50 grams. And for our patient population, that's even getting closer to half a gram per kg. I think we often underdose glucose. It's like 4 calories per gram. So if you give somebody 25 grams of glucose, so 1 amp of D50, that's 100 calories you just gave them. And if anybody has like a Coke or something, I think the whole bottle probably has more than that. So you're really not giving people all that much sugar. Don't worry about it. But they often can have totally normal finger stick glucoses. And then all of this is like this repeat. What I always want to know is this patient getting sicker or better? And so you're you're resuscitating them. But in that process, every time you get a VBG back, my personal recommendation is to get another VBG, get another salicylate level, or at least every time you get the comp back, because you want to know which way they're going. I've seen many patients who you think they look good. That first level is 40, but they have that concretion and they keep creeping up, and you have to keep treating them for a really extended period of time. You want to know, do you need to replete that potassium? If you're not repeating it, then you're giving them sodium bicarb, which we all know shifts potassium, intracellularly. And so you're actually making people with this sodium bicarbonate therapy. If you're not giving them potassium, you're making them hypokalemic on your own. So you do need to follow really closely fluid resuscitation, repeating labs and levels, deciding if you need to repeat giving activated charcoal, controlling vomiting, and just, again, this is probably the sickest patient in the hospital if you have somebody who's really aspirin toxic. And then a little bit of chronic toxicity. Most of what we talk about, most of what the boards are going to test you on is acute. So that's probably the most important thing. Chronic, you're probably not going to have a history of an overdose. They're probably taking something chronically. Maybe they developed a really bad AKI or CKD AKI. Any old person who's altered, it's not an unreasonable thing to do. And how often do we have like, I don't know what's going on with this altered patient. Maybe you're even LPing them. Sending an aspirin level, a salicylate level is not unreasonable. And when they have done studies historically and looked at old people who are altered in the hospital, not even in the ED, who actually have elevated salicylate levels, it's pretty large when you think about what we shouldn't be missing. And any of these patients really, if they're, again, altered, these are all altered patients, just dialyze them.
Don't forget to talk about
Yep.
A lot of things are happening.
The things that I've seen that are the worst are actually like BC powder. So we don't get it as much here, but people from the South use these like powdered, you guys know. And these are like very concentrated, like more than just like 324 that people are like dumping into their glasses of water and chugging it back. And so some of the worst older people toxicities have been that in my experience. But dialyze them if they're altered, and just add this to your differential for altered old person who shows up. It's an easy enough, cheap enough test that, unlike the acute ones that have a clear toxidrome, their toxidrome is just like altered with AKI, which I'm sure we've all had and not sent an aspirin level for.
Chronic, a lot of people get really, really sick around 60. I don't know, or even us, 70.
Yeah, and that's why it's like for almost any level, I would just probably dialyze, and that's just because where the aspirin is and where you're measuring it. So like when you measure 100 in a person who's breathing really fast, it's not in their brain. So when you measure it 60 in a person who's old, passed out, and not breathing really fast, it's in their brain. So the 60, though lower than 100, probably represents a higher total body aspirin level. Um, and the quickest way to shift it out of the brain is just to remove it, and then just through equilibration, you'll get it out of the CNS. But they're sick. Old people, altered, just send an aspirin level on. So Solicits have diverse targets. The main way to diagnose it isn't even with the lab, it isn't even with an aspirin level. It's looking at the patient. They're tachypnic, they're uncomfortable, they're vomiting, and then they have this mixed metabolic acidosis, respiratory alkalosis. Fluid resuscitation is key. Sodium trapping, activate charcoal, keep that K high, dialyze for greater than 100, and treat just all AMS with glucose. I figure we can just do all. So we're going to be able to recite the mechanism of toxicity very simply for acetaminophen, differentiate an RSTI from an acute ingestion, identify toxicity in those needing treatment, and be able to manage toxicity. Pretty straightforward. Tylenol is probably like the most annoying of all things, and if you ask 10 toxicologists, you'll get 20 opinions. So acetaminophen, or in the rest of the world, paracetamol, or N-acetyl para-aminophenol, which is why we all write APAP as like the quickest way to write it down. And then it's the second most common of liver transplantation worldwide, the first in the US, and it's the most common single exposure cause of death in the United States. I feel like we don't get a lot of county, but it's like all over the place. So what has APAP? Did you know there's Advil products that have APAP, that have acetaminophen? So when the patient says I took Advil, does that mean anything? It really, history is really crappy. And I have patients who are like, I took 500 milligrams of ibuprofen. Well, that doesn't exist. It means that they took probably acetaminophen. Motrin, also acetaminophen. Tylenol, of course. Percocet. You can get toxic from enough Percocets. NyQuil and Dayquil. Furoset. I feel like our patient population, our neurologists don't recommend this for migraines, but in a lot of other places, this is used as a migraine medication. It's a barbiturate, acetaminophen, and caffeine. Anything with that set at the end generally has acetaminophen. So there's lots of medications that are like combo meds and have that set, Percocet as well. Excedrin, mixture of aspirin, acetaminophen, and caffeine. So lots of reasons to be vomiting, lots of reasons to be sick, and you can definitely get both acetaminophen and aspirin toxicity. Benadryl, so diphenhydramine. This one's blue, so I mean, which always Unisom probably also has a cold and flu one. Anything that has that yellow highlighting medication, that's how you can kind of go through the pharmacy and be like, oh, this has acetaminophen in it. But the idea of this is just to show everything might have acetaminophen. And unlike aspirin, it doesn't have a toxidrome. You can't identify an acute toxic person who's toxic from acetaminophen. You just can't. They look totally normal. They have no signs of toxicity. History is a little questionable, but people often get it wrong because they just don't know what they're taking. Just some interesting 1982, and the person who was actually suspected of actually these murders just passed away this year. So just like an interesting fact, you can go online. There's some really great podcasts and news articles about it. But somebody essentially held Chicago hostage by going in, opening up these Tylenol containers at the pharmacy, didn't seem to be targeting specific people, and replace it with cyanide. And this was a big, giant push for kind of like tamper evident packaging so that people would more easily know if somebody had opened up. Before then, it's just like you open it up and you would never know if somebody had opened up the package. And it's like an entire family, like the 5 people were all like family members who pretty much all died. They like one of them like died after taking it, and then like the next person's like, I have a headache after coming back from the hospital. Let me go grab the Tylenol, and then died. It's They actually pulled every single Tylenol off the shelf in the entire country when this happened. Kind of cool. But nobody really identified it when the patients showed up for cyanide. This is a busy slide. But really the most important things are here, CYP2E1 and the glucuronidase sulfation, and then this glutathione dependent pathway. And this is important because it kind of tells us where our targets are. So NAPQI is the main toxic metabolite that we worry about for Tylenol. Again, testable. And what ends up happening in overdose is you overwhelm the glucuronidase sulfation. And then usually, if you're not even, this 5 to 9% goes to NAPQI, but usually you have enough glutathione without, chronic ingestion or massive acute ingestion that, NAPQI just gets safely metabolized and eliminated. In overdose, you overwhelm the glucuronidase sulfation, and then you shift a lot more towards that CYP2E1. You generate a lot more NAPQI. You overwhelm the glucuronidase, the glutathione dependent pathway, and then you get hepatotoxicity. And there's also 2E1 in the kidney, so you also get nephrotoxicity as well. So what we're aiming to do usually with NAC, it does two things. It shifts us more towards this sulfation arm, but it also restores our glutathione that was depleted previously, and then ends up regenerating glutathione to eliminate NAPQI. So it's a really great magical antidote. And it's good probably for all causes of toxin-induced liver toxicity, or at least maybe some benefit. Anybody know anything else that is or anybody know something that's a CYP2E1 inhibitor? Cimetidine. Anything else? One of them you guys consume on a hopefully not more than daily basis. Sorry. You said caffeine, I think, but it's somebody else maybe said alcohol. Yeah. So alcohol is a CYP2E1 inhibitor. And so a co-ingestion of alcohol plus Tylenol is probably a little protective. And then fameprazole, which is, you guys know what fameprazole is? Not for today's topic, but it's an alcohol dehydrogenase inhibitor. And so that's also a CYP2E1. It is a proposed antidote to really severe acetaminophen toxicity. It is extremely controversial. So we're not going to mention it today, but it's something that if you call poison control, for a really sick patient, they may or may not mention it. You should just be aware that it exists in this case, so you're not totally dumbfounded, but it's definitely not testable. It's not all toxicologists agree, not all anybody agrees. So you don't need to know much about it, just that it might be mentioned. So NAC, what is NAC? It stinks. Replenishes glutathione, kind of, free radical scavenging, which is why it might just be beneficial for all forms of liver toxicity, especially drug-induced. But it smells terribly, which is important for the next part for oral dosing. Before there was IV, there was just oral. So IV is actually pretty new. So probably even when Dr. Silverberg was training, it was all oral. Yes. The trick that was imparted to me by my med school advisor, who was actually a downstate med student, Danny Lugassi, was put it in Mountain Dew, but he also really loved Mountain Dew. Everybody has their own thing that they mix it up with, but Mountain Dew stinks already, and so you guys disagree? Yeah. It stinks. Like if you've ever given a mucomist neb, it's like the whole room smells as well. And so that's actually probably the biggest challenge of oral dosing is just getting it into the person because it's so disgusting. Um, One of its benefits, though, is that it goes straight to the liver, kind of the opposite of other drugs where you're like, oh, it's protective if it skips first pass. Well, this is actually good because it goes right through first pass. So it goes straight to the liver, it gets absorbed right into the liver and kind of can go there. So some people think there's some benefit, but again, it stinks. So that's an initial loading dose of 140 mg per kg, followed by every 4 hour 70 mg per kg. IV, which is like what all of us do now. There are a lot of ways to do this. A lot of places are moving towards 1 or 2 bag things, but I think still the testable thing, 150 is the magic number. 15 is really the magic number for acetaminophen. Why the pediatric oral solution is 160 mgs per 5 ml. Maybe everything used to be 16, 160. Maybe Dr. G knows it's the most annoying thing. But 50 mgs per kg, right, is our dose of acetaminophen. 150 mgs per kg is usually what we think of as like an estimated toxic dose. And 150 mgs per kg is your initial bolus dose of IVNAC. And the total dose that we give in a standard 21-hour course is 300 mg per kg. So again, 15, what we should all lobby McNeil to change the concentration to 150 mgs per 5 ml, and it would make all of our lives much easier. Like why? What's with that extra 10 mgs per 5 ml? If anybody has a theory, please let me know. Because then you can even do, you do like the weight divide by 2 and it works perfectly. But you're always a little bit over for acetaminophen because of that 160 instead of 150. You follow it by a 4-hour bag of 50 mgs per kg over 4 hours, 12.5 mgs per kg an hour, and then 100 mgs per kg over 16 hours or 6.125 mgs per kg an hour. This is the one that you just keep repeating until they're getting better. There are, as I said, some other dosing guidelines. 300 mgs over 21 hours is kind of like what's considered the standard minimum. If you have a really sick patient, I don't want to go into that because I don't think it's going to be tested. I think it just clouds it. And you're almost always good for the first 5 hours with the standard dose. And then poison control, who you should be reporting all these cases to, might say, you know what, this one I want you to keep giving 12.5 mgs per kg an hour. Keep doing that one instead of switching to the 6.125. So you should just, again, kind of like with the fomepizole, be aware that you might be told some additional things, but in general, this is what you should know. This is the testable thing, especially that 150 mgs per kg over 1 hour bolus dose. Know that number. So you can get this anaphylactoid reaction. It's not anaphylaxis. It looks a hell of a lot like anaphylaxis. And you treat it the same way, but the main thing you need to do is slow down the NAC. Almost always, this is over that initial bolus dose, and then you just extend it over 2 hours instead of doing it over 1 hour. You can also switch to oral NAC at that point, but again, it's disgusting. It's difficult. I actually once got on the phone with a patient in a hospital who was like refusing NAC because they got an anaphylactoid reaction and then was like, no, I don't want to deal with this. So diphenhydramine, steroids, and then slow down the NAC, extend it over 2 hours. And then they're unlikely to get it for the 4-hour bag or for the 16-hour bag. You almost never get it off the PO. And it's like every 4 hours, this is really like you only get it with that 150 mgs per kg load over 1 hour. Whereas like the oral, they're not going to even chug that quickly and it's much more slower. So you can alternately slow down or just switch to oral dosing. So how do you know somebody overdosed on acetaminophen? As I said, it's in like everything. You do have to rely on history a little bit. When people come back, when their labs come back and they have an elevated, AST, ALT, it's something you should always think about, and as well as doing PEP panels. What I always kind of recommend is also getting a CK. I would say 9 times out of 10 that I've been called on somebody who they're like, oh, patient has elevated LFTs. We're worried it might have been acetaminophen. Maybe even they have an elevated acetaminophen level, but they got acetaminophen in the hospital because nobody thought they overdosed on acetaminophen. You get you get CPK and it's like 3,000, 4,000. It's not perfectly diagnostic, but it's a little less likely that people have pick'em's dictum, and oftentimes rhabdo is more well explained by their story and presentation. But you need to take that all together with the history. But Tylenol will generally have an elevated AST initially, and the ALT kind of peaks a little later, often in a 2-to-1. So it looks just like alcoholic hepatitis. It's hard to differentiate other than with history and with labs, but also rhabdo looks exactly the same way. You'll have an elevated AST relative to your ALT, generally somewhere around 2-to-1. They can often be very similar populations. So just like keep your differential open for rhabdo for these patients too, which I think that gets missed often. And if they ate fish, maybe it's Haft's disease. So this is the Rumac-Matthew nomogram. The biggest key to here is that notice that it only starts at 4 hours. So any level you get before 4 hours, according to Rumac-Matthew, is totally unreliable and unuseful. There are some studies that will say 2 hours. A negative acetaminophen at 2 hours to 4 hours might mean that they didn't take any acetaminophen. That is not well studied. There are studies that show that this is good, and then there's other studies that show that you miss a few people. Acetaminophen is generally pretty rapidly absorbed, but other things can interfere with its absorption. And so, take that 3-4 hour very carefully. Like if you're going to go that route, that you're going to order a lab for acetaminophen that's not on the nomogram, meaning 3-4 hours, then just make sure that you have everything else checked off really well before you say it's not acetaminophen. So usually our recommendation is just get a 4 hour, which in peds is a little bit more difficult sometimes because you don't want to stick these kids multiple times. Even adults, it's like, how easy is it to get that second one? Like maybe they showed up through CCT. It's like, well, they're here. I'm going to get their labs to 2 hour level, comes back negative, or it's a 1 hour level, comes back negative. Now they're in the pod and it's 6 hours later. Like it gets complicated. I have that red line at 8 hours because there's good data that shows if you start NAC within 8 hours, you're good. You're not going to probably develop fulminant hepatic failure. You're going to do well. If you start NAC after 8 hours, you might do poorly. And so this is important because I generally make my decision based on the Rumac-Matthew nomogram of whether or not to give NAC. If I have a concerning story that I think the person might have gotten a lot of Tylenol, that 150 mg per kg, 1 7.5 gram dose, then I'm maybe saying if I don't think I'm going to be able to get my lab back in time by 8 hours and start NAC by 8 hours, then I'll just say start NAC now. I think some places will say take a dose of the oral because that lasts 4 hours. So it kind of extends your time a little bit. And then if you get the lab back, you can discontinue NAC if it's below the treatment line. But that's depending on where you work. So county, it's probably anywhere from 5 hours, 6 hours when they show up to maybe just give a dose of NAC for any concerning story, because it's going to take an hour plus to get the lab back. It's going to take an hour plus to get the NAC sent up from pharmacy and hanging and going. So just something to think about. But you can do it all the way up to 24 hours, and that's an acute ingestion. Any number of doses that somebody takes, they could take it every hour, on the hour, all the way up to 24 hours. As long as that first dose was within 24 hours, that's the time you use, the moment that first pill went through their mouth, and that's considered an acute ingestion. And then you can plot it on the Rumac-Matthew nomogram. Even if they did this literally 24 times, you can still call that an acute ingestion and plot it on the Rumac-Matthew nomogram. Does that make sense? Now, what about an RSTI, which is this repeated supertherapeutic ingestion? This I almost always see with somebody who has pain, which is why maybe today is a good day to talk about it. They broke a bone. It's almost always dental pain, honestly. And they're just popping acetaminophen back to back to back to back. That's anybody greater than 4 hours who are taking it multiple times that you suspect in total, it's more than 4 grams-ish in a day over that time period. You can't use the nomogram. These patients, if you're like the story looks bad, they're ill appearing, there's anything, the amount of dose, then you just give them NAC right away, like we talked about. But to some degree, the shit's already hit the fan. And then you continue treatment if there's any elevation in their AST, ALT, or their acetaminophen level is elevated. And then those people just get NAC'd, and you keep trending their levels until their acetaminophen level is negative and they have downtrending LFTs. There is no specific cutoff for the AST, ALT. So technically, in like the most recent consensus guideline that was just published this year, if they're elevated, they're elevated. Now, if you think there's rhabdo going on because they also were using cocaine during this, 48, 96-hour time period, then maybe you have another answer that you can consider. But otherwise, any elevation in their AST, ALT. Now, if you have baselines, that also might shift you. But if they're elevated, treat. And for this patient, it's hard to know how long they're going to be here, so it's like a pretty straightforward admit. For some of the other acute ones, like maybe we can eventually do OBS. So decontamination, it's very absorbable by activated charcoal. And so my practice, which comes out of Australian studies and is now kind of embraced by these consensus guidelines I mentioned, is if somebody shows up before that 4-hour where you're going to get a level, give them a dose of activated charcoal. And sometimes you're going to give it beyond the time period also if they took other drugs that extend the period that you might expect acetaminophen to be absorbed. There's also things like HD to consider, which we'll talk about now, which this is just very rare that we're doing HD on these patients. These are the technical extra guidelines, greater than 1,000, do it. This is a very rare situation. They're altered, they have severe metabolic acidosis, they have an elevated, you can just remove it. It's highly dialyzable. We don't usually recommend HD unless you don't have a good antidote. NAC is a great antidote, but these patients are at such high risk of doing poorly that HD is recommended. There are some new guidelines for giving maybe more NAC, as I mentioned. Some people use omeprazole in these cases as well. Not very well evidence supported. So there's a lot of these like new extended release products that are designed to be absorbed over greater than 8 hours, or they might be opioid ingestions, co-ingestions, or they might be anticholinergic. And so these are what we call line crossers. And so you might have a person who's below the line at 4 hours, and then they are above the line at 6 hours. And so the current recommendation is to do a repeat. This is not going to probably be tested for somebody who appears anticholinergic or concerning co-ingestion, one of these kind of time release products, extended release products, to do a repeat of your level 2 to 4 hours after that first level. So, and you want to see if they're going above the line or if they're having like increasing levels or sustained levels. And then you can, these are ones to definitely work with poison control over, like how long do you need to observe them. But if they're clearly opioid toxic or clearly anticholinergic, you're definitely doing this. And then if you know that they took one of these like 8-hour preps, then you're also going to do this too. So now, hopefully some quick cases. You have a 2-year-old boy presents 1 hour after mom found them in the bathroom with an empty bottle of Tylenol. So what's the first step? 1 hour here. Take some charcoal. Does anybody want to get labs on them? Yeah, because you're going to stick them again. So I actually know some people that'll say, don't even go to the hospital because the doctors might screw up and, stick you then. And then we're going to tell them to stick your kid a second time. So, right, give AC, get that 4-hour level, call poison control. Second step, you get the 4-hour level, plot on the nomogram. Very straightforward. This one's like very easy. I don't think anybody would argue it. Well, you wouldn't want to give NAC yet at all. Yeah, it's not like terribly absorbed by the charcoal. I don't think it's well studied. Like, are you decreasing their level of NAC by giving charcoal at the same time? But you probably are spacing them out either way. And what? They certainly can. Giving oral NAC is like so rare. Like it's the person who has the anaphylactoid reaction, maybe the person who, you know, is so sick that sometimes you give extra NAC in these modified dosing methods. Instead of giving more IV, you also give oral NAC for that benefit of it going directly to the liver and going through first pass as opposed to skipping first pass. Kids will drink stuff. Kids will drink anything. Yeah. Kids will drink anything. That's why they're such a problem. That's why they show up. That's why they get sick, because they will drink anything and everything. But yeah, I think oral NAC, just try not to do oral NAC at all. Because like who are most of these patients? It's like somebody who's suicidal, who doesn't want to drink the oral NAC either. That person, getting them to drink charcoal is probably not going to work either. So you're just in like a tough spot. But I would just avoid oral NAC unless you have a contraindication or a specific recommendation to additionally give oral NAC. It's really a historical thing.
In the old days,
yeah,
still loaded them to the oral, gave them a loading dose of oral NAC, and they vomited it, or at the same time they gave them charcoal. We would, instead of giving them the maintenance dose, we give them another loading dose. They want later. That's what we do the other. Now you have the IV.
Yeah. So just do IV. Same patient, but presenting 8 hours later. What do you do? First step. What? Yeah, just give the NAC right away. There's no reason to give activated charcoal. Get the level, see if they plot on the nomogram, where they plot on the nomogram, and continue DC based on the nomogram. Pretty straightforward. So 12-year-old boy, 4 days after dental pain. So this is that RSTI. What do you do? We're at the end. So if you think they look sick, if it's a concerning ingestion amount, then just give NAC right away. But then get LFTs, coags, phospholactate. Those are part of the King's College criteria, which are rarely a problem for the ED to deal with. Acetaminophen, call poison control. And if there's, normal LFTs, negative APAP, you're done. You don't need to keep giving NAC. Or even start NAC if you were like, they looked fine. I don't think I calculated their total dose. I'm not that concerned, but I'm going to check anyway. Because you can be wrong. All right, and this is the final case, which apparently, I think I hit it too many times trying to get it to go. So 2-year-old boy, 5 hours after finding them with pink vomitus and confusion. So this is pink vomitus is often, it could be Pepto-Bismol, but it's often diphenhydramine, Benadryl products, and then repeat to see if they're a line crosser. And I think before accident was at 2 to 4 hours. And so just repeat to make sure they're not crossing the line now. And that's kind of it. CYP2A1 is your enemy. That's kind of one of our targets. NAC is our main treatment. And giving AC prior to 4 hours just might save you having to treat somebody because it might get them below the treatment line. Pre-4 hour levels, unreliable. Really just don't even think about doing them. But sometimes in CCT, sometimes sick adult patient especially, it happens. You can talk to poison control if you want to avoid doing a 4 hour level. But that's a lot of history to really think about. Timing of the first dose for within 24 hours is how you plot on the nomogram, and is still counted as an acute ingestion, even if there are multiple ingestions. Limited role, but really only in severe toxicity, RSTI, multiple doses over 24 hours, and then extended releases, anticholinergic opioid, toxidromes, repeat the level 4 to 6 hours.